So we'll start with Nancy. So Nancy Poole is Director of Research and Knowledge Translation at the British Columbia Centre of Excellence for Women's Health in Vancouver, Canada. She has over 20 years' experience in research, policy and practice related to health promotion, prevention, treatment and harm reduction for women with alcohol, tobacco and other substance use problems. She was the 2009 Healthway Health Promotion Visiting Research Fellow sponsored by Curtin University and the Government of Western Australia, where she worked with Aboriginal communities. Nancy is also known in Canada for leadership in piloting online participatory methods for knowledge generation and exchanging on women's health, including virtual networks and online communities of inquiry. She's got a wonderful technologically advanced mind. Probably comes from her early work as a roadie and sound technician with a rock band, I think. That's not in her CV.
No.
Dr. Lorraine Greaves is a medical sociologist and senior investigator at the British Columbia Centre of Excellence for Women's Health and its former executive director from 1997 to 2009. Prior to that, she was director of the Centre for Research on Violence Against Women and Children at the University of Western Ontario, Canada. She's held positions in academic, government, education, and non-government organisation settings. Lorraine is an international expert in women's substance and tobacco use, gender and health promotion, the use of sex and gender in research, program and policy development. And she was the recipient of an honorary doctorate in 2007 from the University of Ottawa for her work improving women's health. So it's over to you. Thank you very much.
Thank you very much, Marilyn and Rita. And I want to start there by thanking both of you for your support of this project. In particular, Marilyn, as she's explained, agreed in 2008 to be an official partner in this project and to commit resources to it and staff time. And that proved to be a wonderful decision for all of us. And Rita, you supported that process since you arrived here to run Women's Health Victoria. So we're quite grateful. It was really important to us to have an international partnership with Women's Health Victoria because of the reasons Marilyn's mentioned, because this was a topic where theory is one thing, but practice is quite another. And it's a topic where we were struggling very much in this book and in this entire project to bring those two things together, theory and practice. So it's really a story about praxis. And as we have heard, we had a blank slate. We knew there was something wrong with health promotion for women. But, you know, other than sort of expressing a general malaise in 2008, we weren't clear how we could help people do it better. And we thought we needed to actually wipe that slate clean, to think about it from the very beginning. So indeed we did. If you're in health promotion, you'll know about the Ottawa Charter. And you'll know perhaps about the Bangkok Charter. And you'll know perhaps about the World Health Organization's Commission on the Social Determinants of Health. Those three things, 40 years, 20 years ago, and in the last 10 years, guide a lot of health promotion in the world, not just in women's health by any means. And so we thought, well, best we start there. So we actually took a look at those documents and found, to our chagrin, that the Ottawa Charter set the stage for including gender in health promotion quite well. The Bangkok Charter retreated a little bit from that. The Social Determinants of Health Commission also acknowledged gender as one of the social determinants of health, but all of them fell short in affecting health promotion practice over those 40 years. And we found that not only was gender barely integrated, if it was lip service, and most of the time it wasn't there. Further, we realized that all of the social determinants of health are in fact gendered. But that didn't come through either. So we had quite a job ahead of us. And we're happy to leap forward to say that we're celebrating today with you. This is the first launch of this book. The next launch will take place in January in Vancouver. And we're thrilled to be here to do this. And we're hoping that you'll be able to pick up your copy here later today and take it back to your organization and read it and try and make change. And we're going to talk about that. So today, I'm going to tell you a little bit about the introductory part of this book, a little bit about what products we created, a framework, a tool, and some other bits and pieces that we'd like to share with you. We're going to give you 2 or 3 examples of how we analyze this against some topics, some typical topics in health promotion. And then we're going to conclude with a look at the future and what the mutual challenges are. And I can tell you, this book is not the answer. This book is a set of questions and a set of challenges. Here are some of the contributions that we want to acknowledge. And you've heard that Petra and Rose did write in this book. Helen and Marilyn also did as well. But why do this? Gender was really very often missing, as I've said. And we got a grant based on that premise in 2008 to bring an emerging team together. So that meant we could bring disparate people together for 5 years to study it. We surveyed the literature, analyzed some key areas, developed a framework, a tool, a book, numerous journal articles, and now we're just about to launch a legacy website. And one thing that will be on that legacy website that we haven't yet mentioned is an online training tool that will bring this book to life in a very different way. A serious transformation in health promotion practices is long overdue. Similarly, reducing gender inequity in the wider health and social and economic arenas remains a pressing worldwide issue. In our view, these 2 issues can and must be tackled together. And that's where we ended up. You might think, how did it take 5 years to get there? But it was a very interesting process to wipe that slate clean, take a look at what was being done, deconstruct it really, bring some gender theory in to assist us in thinking forward about, okay, how can we frame what we really need in a way that is going to be understood and useful? And that was our challenge. So we knew that integrating gender into health promotion had failed, to put it simply. We'd had 40 years of trying to do that. It hadn't happened particularly. When it had happened, it had often been very negative or exploitative of gender roles, relationships, gender stereotypes. So even when gender or gender relations or gender roles were acknowledged, they were often acknowledged in ways that didn't, in our view, help. So integrating gender was one thing. It hadn't happened. When it had happened, it hadn't been very good. So we realized we had to raise the bar. And that meant how we would transform, which is the verb we came to use. So we discovered that the main tropes in health promotion were paying only lip service, and we needed to change that. Early on, we realized power matters. And really, this is in some ways the crux of the problem for not just women's health, but for women's status. The unequal distribution of power in every way, from the household to the wider community, to the global arena, continues to dog us. And I think it's very interesting for us to consider that this is a problem that's global. We often are challenged to think about high-income countries and middle-income countries and low-income countries and kind of make different arrangements in some ways in our thinking around those things. But when you actually come back to these concepts, it's a leveler. Women are experiencing this, it's a relative concept, but experiencing this pretty well everywhere. And there is perhaps no better example, or worse example in some ways, than violence against women, which, as we're learning, more and more with each passing week is a global issue, is generally hidden, is often responded to with not some very unelevated responses, and certainly structures encourage it. So this business about power is crucial to the World Health Organization because it's an enabler, but when we're shifting the gaze to women and around from individual behavioral change to a shared social responsibility, it immediately surfaces the question, how do you structure a world where power is more evenly distributed? So our part one in the book looks like this: envisioning gender transformative health promotion, a chapter about power, what I've just been mentioning, and a chapter on diversifying health promotion. And diversity clearly matters. This is a chapter where we critically engage with an intersectional approach to gender and gender theory in an attempt to try and figure out how it could or could not contribute to a gender transformative approach. And addressing the other question is perhaps one of the best ways we can do that. When I see something that looks racist, I ask, where is the patriarchy in this? And you can flip that question on almost every single situation that you look at. When you see something that is homophobic, or when you see something that is inequitable economically, flip the question to try and generate that diversity mentality and that intersectional brain. So Nancy's going to also pick up at this point as we talk through some of the actual products that we created. This framework, I know it looks daunting, it is, but I'm sick of looking at it. But anyway, we're going to tell you about it. Because we were here in 2012 and actually consulted with a group that Women's Health Victoria drew together. And that was a very critical turning point for us as we developed and redeveloped this framework. We also had an online survey. We also had individual consultants who anonymously responded to this framework from a variety of countries. And we took all of that back and redeveloped it with the team. So this process of developing this was, in fact, about a 2 or 3 year process. And in the end, I know it looks complex, but in the end, we basically take you from the position over here on your left, from gender inequity, to a position on the right of gender equity. And in the middle, offer you some ways of thinking about how you might look at gender. And this is useful for you in your own organization or for you examining other people's responses as well. Gender unequal, gender blind, gender sensitive, gender specific, gender transformative. And I think it's kind of self-explanatory when you read in the little boxes what all the possibilities are. Many of the health promotion programs or policies that we currently encounter are gender blind. Gender neutral, you may also call it. In other words, they ignore gender. And we feel that that one-size-fits-all business is not necessarily a good idea all of the time. So that takes some critical thinking. Some of them are gender-specific, where you actually acknowledge and consider different needs of women and men, but you don't necessarily do anything about changing them. And then, of course, gender transformative is where we landed because it attempts to change those harmful things at the same time. So across the bottom, the key things to remember are the exploit on the left, accommodate in the middle, which is a neutral stance, and transform on the side. So this underpins this framework. And this framework...
If you just flip that for 1 second. I think Marilyn did a good job of mentioning how oftentimes in health promotion work, people pick one small piece of something like gender specific and think about, well, for instance, in in tobacco programs for women, they look at the issue of women being concerned about their weight and things like that, and think, oh well, we've thought about that, we've addressed that in our little program, and so we're gender specific. And then they measure those kinds of programs and say, well, did gender-specific tobacco programming help? And of course, they don't find a big help in just having thought through about women's interest in their weight and the possibility of its relationship to smoking. And so I think it turns out to be, even though it is a lot of words on a slide, I think it is kind of an interesting way of looking at at programs that you may be involved in, that brings kind of a lens to it that helps you when you're talking with others as well about how is the program you're trying to set up placed on this continuum. Is it merely accommodating as opposed to transforming, and what would be that next shift towards a transformative approach? And so in a lot of the workshops we've done, I feel like this continuum has been kind of helpful as a start off in terms of thinking, where are we now in what we're offering, and how does it fit on the continuum, and what's the stretch towards moving to that other place of thinking through what might be transformative as opposed to simply sensitive or specific or informed about gender. So I think it can be a really useful piece that a number of the chapters in the book really pick up on and think about where we are on different topics and in different settings and with different populations.
Yeah, it is interesting, and perhaps the gender unequal part is one of those areas too where you can feel, oh, there's something wrong with this program, but maybe this will give you words to address it. One that I recall, again in the smoking arena, was a presentation that I heard once, which was entirely built, it was a health promotion initiative to reduce secondhand smoke in the household. And it was built entirely around asking women in a country, by the way, that had virtually 1 or 2% smoking rates, to ask men who had 40 to 50% smoking rates to not smoke in the household. Well, where do you start? And this was under trial, had control groups, this was a big deal, this intervention. And it was based on a gender unequal premise, where you were actually potentially putting women at risk, let alone blatantly preserving inequality, actually putting women at risk by asking them to do that kind of work in the privacy of their own homes, when nobody had ever investigated what the options were, what the responses might be, what other measures might be necessary. So that's an extreme example, but we would challenge you. You don't have to go far to find those, and you certainly don't have to go far to find gender blind or gender neutral ones in the middle. You do have to go far to find gender transformative ones, as we discovered. So this was the framework I was referring to that went through so many consultations and revisions. And it takes you into kind of a bird's eye view of this field. The health determinants on the left, there are more than social determinants. There are also biological, genetic endowment determinants and environmental issues that determine not only what happens to you, but what your epigenetic outlook might be. So, we propose all of those are gendered. On the right, we set down the goal, and that is a gender equitable outcome for women, not just in health, but in social and political and economic terms as well. So again, moving from left to right, we realize that there are ways in which these gender determinants get manifested in systems and structures through discriminatory practices and values and norms, differential power. It manifests in health policy, research and services. It's not it's not hard to see how this translates when you start from a premise of gender determinants and discriminatory practices. And then in the middle, you'll see those familiar 3 options about exploitation, accommodation, and transformation. which roughly you can categorize most health promotion interventions into one of those three. And then the challenge of decreasing bias and reducing inequity to end up with this outcome. So what this offers you is the bird's eye view of where you're starting and where you want to head, and how these mechanisms feed each other into a system.
And why feminists need to have a sense of humor, right? In terms of plowing through all of this, and a sense of durability, I guess, to make it through all the multiple research documents we read to get to a vision of this. But I think, you know, the thing that was really interesting was all those conversations, and Petra and others I'm sure can talk to you a little bit about, you know, being on the other end of the web meetings as we wrestled with trying to think through this, you know, this work together. And it seems sort of simple now that you see it, but it, you know, involved a lot of conversations, and I think it's a really great piece in some ways for those who are interested in the theoretical foundations for what we're going to now unfold in terms of the practical applications. But for me it was an important piece to think through this in a really rigorous way and a fun way in many ways together, so that we could in turn do the translation from a place that we can argue with the research and the policy folks as well as the service level people. And I think that was one of the more profound pieces, was that spot there that says health policy, research and services. And Marilyn, you mentioned it in terms of the various levels as well. That fundamentally, if we spend time only thinking about health promotion from the individual level and from what we offer as service providers or community advocates, then we really are going to have more centuries of, you know, not advancing this, that we have to pull it up to be thinking more transformative on the policy and research levels, as well as integrating that in the individual work with women and our own service cultures and approaches. So yeah, you know.
Yeah, Nancy's right. After, you know, decades of, felt like decades, years actually, of thinking this through, I think the importance is that it gives you the words to use as you go forward, and it gives you a bit of an explanation as to what the roots of the problem are and where you could go to solve it. I mentioned earlier those charters, the Ottawa, the Bangkok, and the WHO Commission, in a negative or neutral way, but I do want to say that in 2007, alongside the WHO Commission on Social Determinants of Health, there was also a Women and Gender Equity Knowledge Network formed. And that was very helpful to our thinking as we began to build this research team. This report, and I'm going to quote, boldly states, quote, "Gender inequality damages the health of millions of girls and women across the globe." They go on to say that, quote, "Taking action to improve gender equity in health and to address women's rights to health is one of the most direct and potent ways to reduce health inequities and ensure effective use of health resources." So that was in some ways kind of a green light for us to understand that a group of women and men had actually spent 2 years thinking through the impact of gender on the Commission and the Commission's report and all of the social determinants of health, and made it a little bit more complicated by challenging in a bold way the whole notion of inequity. So that reinforced our thinking and allowed us to really propose not only the framework, but these principles as well. So we're going to take you through these very briefly. Evidence-based, to us, goes without saying. We're a research-based organization. This was a research grant. So we wanted to know, how can we actually derive or generate ideas so that people can derive the evidence to support this approach? Equity-oriented, I've just mentioned. The role of equity in health is well known now, and the role of gender in inequity is also well known, so we put those blocks together. It's also action-oriented. As I said at the beginning, we didn't want to just do this for the theoretical fun. We wanted to know how it would be applied. And true to our tradition was women-centered, culturally safe, and trauma-informed. Nancy, you might want to mention what that means.
Yeah, a lot of work we've been doing of late, and the previous book we edited together was on this concept of being trauma-informed. And it's a concept that hasn't been as much talked about in Australia, I find. I've been here a couple of times speaking about it. But the main thing I think that it is really important to get is that it's not about treating trauma, but it's about creating an approach that is woven through every type of service at every level and policy as well, that really thinks about the fact that a number of people who are coming for help will have experiences of trauma, and of course particularly women will. And so how might we take into account that in all the ways we work with them? And I guess it starts in the sense of health promotion in terms of not working from a medical model, not starting from the place that you have to have a diagnosis before you can do anything, but much more not forcing disclosure in services, not starting with that as a way of interaction with women, but recognizing that's probably there. At some point we'll be working with that at some level, and the way in which we need to work as we deliver health promotion is with that sense that women who have been overwhelmed by various types of trauma, whether that's as refugees or whether it's as children who were neglected or whether it's due to sexual assault or any of the various types of trauma that women may experience, that, you know, if you've had that sense of overwhelm and lack of power, the most important thing we can do is create services that are safe and that promote that sense of being able to control what's going to happen to you as you engage. And that just being such a fundamental principle to everything we do in health promotion and every other level of service that we deliver. So there's really such a lot of energy in Canada now. All the governments in many of our provinces and territories are really thinking through about what does it look like at a systemic level as well as a service level to promote this idea of people coming for help in ways that honor their challenges and in having been safe in their lives, and what do we do differently because we know that a high proportion of people coming for help will have experiences of trauma. So I think it's it's one that is really an important one in the concept of gender transformative health promotion for women and in much wider senses as well.
We also, Nancy and I have worked a lot actually in the addictions field and substance use field with women, and not only, but in particular with women who are mothers or pregnant, which I think ranks as one of the most wicked problems in terms of public policy and responses from healthcare and responses from medicine and responses from health promotion. So we've been steeped in harm reduction and strengths-based work from that area, and thought that bringing that bringing those forward as principles of gender transformative health promotion is also valuable. Harm reduction is actually doing no harm and or reducing harm. Simply put, it could be encouraging someone to smoke 10 cigarettes a day instead of 25 and helping them get there, and not necessarily demanding that they quit smoking, which would be not trauma-informed and not very women-centered and really not necessarily harm reduction-oriented. That's a very concrete example, but there are many other examples where you can apply that kind of thinking to bring forward a harm reduction orientation. And strengths-based just makes sense. It actually begins where women are, begins where communities are, begins where people are. Eliciting their own strengths and hopes and dreams is a wonderful place to start in health promotion, as opposed to laying on goals that are determined or predetermined. So in section 2,
in the book, I think we found that the principle piece was particularly helpful in areas where complete gender blindness had happened in many ways, or there'd been a lot less action on health promotion. And so where we didn't have initiatives to critique in some ways, we had the principles to begin with in terms of people asking questions. And so if you look at the bottom chapter there on rethinking preconception and maternal health, that particular chapter really thinks through what might health promotion look like in the preconception period, and how might we apply some of these principles to take us to a place where it's a gender transformative piece, not simply a piece of individual women trying desperately to make individual changes in that period. But generally, section 2 is a really, I think, an interesting one, because we took all the theory and principles, etc., from section 1 and invited a number of people to think through what that might look like on these various health topics, on tobacco, on alcohol and physical activity, on heart health, on housing and violence, on mental health promotion in the workplace, and on maternal health. So I think it's a really useful piece as you go through, because it gives you a sense of how people are grappling with these issues in multiple locations, and gives you a sense to see how your work may line up with the way in which people are coming at gender transformative health promotion. Do you want to read this quote? Or?
Well, this is a reflection of this section, where we chose different cases or examples to bring forward different views. There's sort of some standard things in health promotion about setting, population, and issue. And we did build on that, because it's important, actually, to use those strengths in the existing strengths in the health promotion community and the health promotion mindset to go forward. So we tried to get that, different locations, if you will, different levels of assigning women's responsibility, different stigmatizing forces. So we tried to pick examples that brought illumination to these differences that sometimes occur in health promotion.
And then we created another diagram.
By this time you're saying, save us. This is your last diagram.
Just so you know, it's the last one. But I think a lot of people, when we first consulted on the framework, said, so what do I do? And so the first feedback we got from here and elsewhere was, give us a tool that helps us translate it. So that's what this is. We went back and thought through some of this. As Lorraine said, we thought about some of the questions you might ask yourself if you're trying to design health promotion with a specific population in mind, or even that you might think about a population where you instead have been working in kind of a generic way. We did the same thing of asking ourselves some questions about settings and issues that might prompt you as you start to think through what gender transformative health promotion might look like. But for me, I think the most important thing that we did was come up with this stuff on the one side there, the engage, analyze, review, identify thing, because otherwise you can see this as a planning process that you might normally see, that idea of, do some analysis, implement, evaluate, report. But you'll notice there's a number of steps there, and I think that, I think it's worthwhile just stopping and looking at it. The first piece I think that is interesting is that emphasis on engaging more than one type of person in doing the planning. So including women with the health problem, researchers, policy folks, and service providers all together, and thinking what this might look like, and doing some transdisciplinary and different sector views to thinking through how to do gender transformative health promotion. Then, you know, that idea of analyzing the evidence for the particular population setting an issue through a sex, gender, and diversity lens. And then here's a step that isn't often done, I guess, is reviewing existing health promotion practice by critically examining gendered beliefs and discriminatory practices. And that's where that gender continuum, I think, really helps us think through. So we may have done analysis before, but this added piece of review of current health promotion practice, I think, is in a critical way is really helpful. And I love the fact that they chose on the front of the book to take a strip off of the current approaches in some ways. And I think we need to do more critical thinking in that way. And then identifying ways to improve women's health and change harmful gender norms, roles, and relations in the intervention. So having those kinds of engage, analyze, review, identify steps, I think, gives us a little bit of a leg up in terms of how we actually do this work.
And this business about identifying, I know it's nice and neat in one little box there, but that's the hard part. That's what makes your head hurt. And we did work through a lot of examples where we thought, okay, what would this look like? And it is a challenge. We'll get to that in a few minutes as we close. It is a challenge, and there's no doubt. It's not only a challenge to advocate for this approach and explain it to others who haven't spent 5 years studying it, but it's a challenge for ourselves as well to actually think through, what could this look like in my area, my agency, my program, my issue? Because we are not trained to do that. And so I don't think we should underestimate the challenge of the identification.
So I just pulled out a couple of examples of two of the chapters in the Section 2 area, the one around tobacco and the one around alcohol. And this first piece in it just talks a little bit, I guess, about the way in which we engaged, analyzed, reviewed, identified in relationship to tobacco. And so, you know, there's lots of work we did to think through about tobacco marketing and about how health promotion efforts really need to integrate gender and equity on this particular issue. And so we came up with some gender transformative approaches that we saw beginning to emerge. These two happen to be our own, but we, you know, in other cases we did notice other people's work as well. But really, this guide around, because Lorraine's such a world expert in tobacco, you know, the work we've done both in developing this liberation guide that takes forth a trauma-informed, women-centered, harm reduction-oriented, strengths-based, etc. approach to women's smoking. And, you know, I think it's just really important for people to recognize that this is heretical in the area of women and smoking, because basically, you know, the idea is that you stop, and that's the only conversation we're willing to have. And to open the door to thinking about ways of engaging women, of bringing in, addressing the determinants of health, addressing stigmatization, and improving women's sort of lens on how tobacco is being marketed to them as a way of liberating them from smoking is really been interesting. And the same with the piece on the bottom, the Couples in Smoking booklet we created, which help couples where the woman's pregnant look at their tobacco interaction patterns. And is there a place for women to be able to quit in pregnancy? How does that look in their interaction patterns? Is it a controlling one where, you know, women are really forced to quit? Is there an accommodation to it where there's not encouragement to help? So we look at the way the couple organizes themselves around that. And it's interesting because in British Columbia, our government has refused to circulate this booklet because we have taken a harm reduction oriented and wider lens on it. So really important, I think, for us to be having these conversations that take it to a different place.
It is interesting because the Couples and Smoking booklet is evidence, they're both evidence-based, but the evidence in that is published in a journal, a paper I wrote with some others that actually uncovered in our data from our couples areas of conflict, in some cases verging on abuse or potential violence within couples, that alerted us to the need to start categorizing these dynamics and talking to women in particular, but also men, about what their dynamics could be and how they needed to at least acknowledge to themselves what those dynamics are. So this, by the way, is being presented tomorrow at the World Cancer Congress. If any of you are attending there, you can come and hear this. But it is depressing when governments won't circulate something because it actually is about harm reduction.
Here, the alcohol chapter, one of the things that we started with there in terms of that analysis piece was the fact that a lot of surveys in Canada, all of them prior to us working on this chapter, actually used the same criteria for binge drinking in men and women, even though we know that alcohol impacts women's bodies in much more serious ways. Can you just flip to the next one for a second? And so recently in Canada, we have been working on this idea of what does lower risk drinking look like, including having gender or sex specific criteria for what is binge drinking. And I like the one Quebec group that called, put it out as a poster that says it's not sexist, it's science, right? Just to flip back, what we found was when we forced when we got some money from the government to look at reanalyzing the Canadian Community Health Survey data based on different levels of criteria for binge drinking, with females as more than 3 drinks being called binge drinking and males more than 4 drinks, we found that it doubled the number of risky women who would be categorized as risky drinking in Canada. And more importantly, for me, was that it showed that in some cases, such as young adult women, young adult females were more likely to be risky drinkers or binge drinkers than younger boys. And for those of you who know anything about the substance use field, for years and years and years, it's always been considered a male problem. And women really, they're much less likely to use, and really we don't need to attend to that whatsoever. And this changed a huge piece by doing this work of gender-based analysis. And
the announcement of the low risk of drinking guidelines was made by our federal health minister in about a year and a half ago. And it was the very first product of our project, really, that we could see as policy impact.
We did this.
We're running short of time, so we're going to move
just
faster.
Yeah.
And this one...
we can just flip through those. We can come back to them if people want, and you can talk about part 3.
We'll just talk about the end of the book and what it looks like going forward. Then we'll have some time for questions. This is the section, and you can see the sorts of things we address. And this is the section where Rose and Petra's work is highlighted as well. Certainly looking at Taking a Stand, the program in Women's Health Victoria around violence against women. A very important chapter, and the chapter on advocacy too. So not only has the movement been silent, there's been virtually no ground tilled on the ideas. We've got a big job ahead of us, collectively. And this book is an attempt to start that conversation in the wider sphere. And we need to get specific. And this is some slides here about some of the challenges ahead of us. We need to be more articulate about these kinds of links that I've mentioned here and start measuring them as well. Because when you actually look at the goal of transformation or reduce gender inequity, you have to say, so how would I know it if we got there? What would it look like? And these are some concepts that we can begin to think about, including in our health promotion work: autonomy, freedom of movement, decision-making power, engagement, etc. We need to get creative, for sure. The practices of participation and engagement, in some ways, I think, have declined since consciousness raising was the main mode. And now we have to do consciousness raising online, which is not impossible and is in fact happening. And that is a wonderful thing to see. We're experiencing a surge of major public figures in Canada and the US who are being charged with sexual assault and sexual abuse of historical nature. And the conversation may be changing on things like that because of the online communities. We have a hashtag, been raped, never reported, that was started on a whim in the wake of one of our current scandals, and it has now gone around the world with something like 800,000 reports listed through Twitter of women, and some men, who've been raped and never reported. So consciousness raising in the digital age is something we need to attend to. And getting further into the online community to generate some of these concepts and putting names to some of these goals. On the other end of the ledger, though, demanding accountability. You know, we do have some documents we can use, and we ought to pay more attention to that. And this is where the advocacy comes in. How do we actually generate that accountability? How do we use the existing human rights, patients' rights, women's rights documents, even the CEDAW document level at the global level is important for us to use in all of our countries to make demands and see what's responding. We have to generate way more praxis, and we're doing that. We're creating manuals, books. This question about how do I do this is a really important one to answer. And so it's a challenge to all of you. And certainly the doing it better is one of those answers in the Australian context. This is a book. We have a manual on the same sort of thing where you can say, okay, you're interested? Here. This is how you do it better. And this is just one page out of the new Doing It Better guidelines, which take a version of the planning tool and actually ask, ignore, exploit, accommodate, or transform. We can choose. And certainly last, not least, using all the mechanisms we have to face down sexism and misogyny. I think that in both Australia and Canada, there's some very interesting challenges in this regard at the moment. This is not going away. And I think it's very important for us to be courageous in this context. Very important for us to name anti-health practices, not be afraid to do that. And here are some examples here. And certainly I just put a mention here of Our Watch is one way of looking at that problem around violence differently. Going forward then, collecting important, useful data to support this, looking at some programs, and in the book there are examples of programs in Chapter 3 that we found, and on our online training, and in the in-person training that Nancy and I are doing next week, actually in a variety of locations in Australia, we give those examples and work through them to inspire all of you. So onward, what we'd like to say now is that you can pick up a book, and we hope you do, because we can't carry them anywhere. And you can either pay, or you can purchase it online and take it with you today and purchase it online if that's easier for you. So I just want to thank you very much for being interested, and thank Women's Health Victoria, and in particular Rita, Marilyn, Helen, who's not here, Rose and Petra, for their involvement in this project. It's been a pleasure.